This meeting. My name's Councillor Watts. Before we start, I'll go around the room or online, I'll go around the room first and ask everybody to give their names. So, as I say, my name's Councillor Watts. I'm the chairman of this committee meeting this morning. To my left, needs no introduction at all. We have...
I'm County Councillor Jackie Strong and I'm the chair of People Committee, and it's a joint meeting with together this morning, so welcome everybody online.
And then from my right hand side we've got Councillor Birch, Cabinet Member. Say good morning.
Good morning, Sarah Birch.
And then we'll go from my left hand side.
Councillor Marion Howells, Clonbarrack and Usk Ward, Monmouthshire.
Councillor Maureen Powell, Castle Ward in Abergavenny.
Hello, I'm Councillor Penny Jones, Raglan Ward, and Vice Chair of Public Services.
Good morning, everyone. I'm Councillor Christopher Edwards, member for St Kingsmark Ward and a member of People Committee.
Morning. Sue. Yeah, I know it's you, Sue, yeah.
Councillor Sue Riley, Bulwark and Thornwell, a member of People Scrutiny Committee. Thanks.
Okay, so we've also got then, I'm going to go on the screen, we've got Tudor.
Yeah, what did I? Good morning, Tudor Thomas, County Councillor for Park Ward. I'm not a member of either committee, but obviously been invited today to come into the meeting. Thanks.
Good morning. We got Ian.
Ian Chandler, so County Councillor for Lantyre Ward and Cabinet Member for Social Care Safeguarding and Accessible Health Services. So a particular interest in the outcome of the discussion today.
Dale.
Hi, I'm Councillor Dale Rook, representing Chepstow Castle and Larkfield wards, and I'm a member of the Public Services Committee.
Yeah, and then we've got Angela.
Angela Sandoz, County Councillor for Mega East and Undy Ward and Cabinet Member for Equalities and Engagement.
Thank you. Anne.
Yes, thank you very much for the invitation to join us this morning. Good morning. I'm County Councillor Anne Webb and I represent St Albans, Llandogo and Tintern, but called St Albans Ward.
Thank you, Anne. Peter.
Hi, Pete Strong, County Councillor for Roggett, deputising as member of People Committee for Maria Stevens this morning. Thank you.
Thank you. And then we've got Steve.
Member for Overmono Ward in Monmouth and a member of this committee.
Jill.
Good morning, everyone. Jill Bond, representing the people of West End and Caldecott. Thank you.
Louise.
Good morning, Councillor Louise Brown, representing Shire Newton Ward and a guest councillor for this meeting.
Dave.
Thank you.
Thank you.
Good morning, Borada. David Jones, member for the Criconi Ward. I'm not a member of either committee, but welcome the opportunity to join this morning because it's a factor that will interest and affect people in the area that I represent. Thank you. Diolch.
No, you're very welcome. And Sue.
Good morning, thank you. I'm Councillor Sue McConnell. I'm the County Councillor for Cressonon Ward, not a member of this committee, but obviously of great interest to myself and residents here in Abergavenny. Thank you.
Indeed, yeah. And Jan, welcome, Jan.
Good morning, I'm Jan Butler and I'm the County Councillor for Goitrevauer. I am a member of the People Committee and I am also a volunteer with FLICE. Thank you.
And as if by magic, Phil appears from literally nowhere. Welcome, Phil. Would you like to introduce yourself?
Thank you, Chair. Councillor Phil Murphy, member for Coent and looking in on this committee.
Okay, yeah, your time is always as slim as mine. Well done on that, Phil. So we also have Paul Meisen, have I pronounced that right, Paul? Welcome, Paul. And we've also got Hannah. If you'd just like to introduce yourself. I noticed we've also got Dan Davis. Dan, I promise you I won't try to reintroduce you as a member of Monmouthshire County Council as I did last time, as I asked you to open the door for me. At which point you said I haven't been working here for 3 years. Welcome, everybody. Paul, if you'd like to introduce yourself.
Paul Meisen, I'm an Associate Medical Director for Clinical Transformation and a consultant physician.
Yeah, Hannah.
Morning, everyone. My name's Hannah Evans. I'm the Director of Strategy, Planning and Partnerships at Narren Bevan Health Board.
Okay. Welcome, everybody. So I'm going to open the floor to... I'm going to seek apologies, of course. So apologies for absence, please. Have we got any...
Yes, Chair. Apologies from Councillor Crook.
Okay. Declarations of interest. Penny?
Yes, Chair. I'd just like to declare that I'm an independent member of the Narren Bevan Health Board, but it's non-prejudicial.
Thank you. Yeah, and it's public open forum. I can't see anybody here. There's nobody online, is there? So we go straight into the proposals for Neville Hall Hospital, and we've obviously got the documents in front of us. What I'm going to do, though, is I'm going to open the floor up then to our guests, really, for them to introduce effectively and explain to us what those proposals are, also the timeline as well, so we can fully understand. And then the usual format, I'll open it up to members, if the people in this room who are on these joint committees, with Jack and I, and then I'll open it up to then other members, and then at some point, if necessary, if the cabinet member wants to, or cabinet members want to pitch in, we kind of make it up as we go along, if that's okay. So yes, if you'd like to, the floor is yours, Narren Bevan.
Brilliant. Thank you, Councillor Watts, and thanks for the opportunity and the invitation to join you this morning. I have some slides which I will go through just to bring colleagues up to date with the work we're doing around Neville Hall at the moment and how it fits with the wider plans for the Health Board. And then happy to take questions, make sure I leave plenty of time for questions. Is that okay? Okay for me to share my screen?
Of course.
Thank you. Just bear with me. I don't think you're seeing the right slide there, are you? There. Is that okay? Can everyone see there's just the slide? Yeah. Okay.
It's brilliant. The only thing is, there's a slight bit of feedback there. I don't know if someone's mic's... is someone else's mic on? Or are we on joint? Okay. Carry on. Sorry. Go ahead.
Okay. So we've introduced ourselves. So a couple of things I just want to cover this morning. Share with colleagues the context for the work we're doing around Neville Hall, and an update on some of the recent plans and developments. A bit about the why we're focusing on Neville Hall at the moment, and the context of the reinforced autoclaved aerated concrete, which we call RAC for short. I'll try and keep my acronyms to a minimum. I know we do have a tendency to sort of slide into them in the NHS, but RAC will come on to talk about how that sort of is focusing our minds in the north of Gwent at the moment. Set out some of our thinking around our long-term ambitions for Neville Hall, the site, and importantly the services on it. And then talk about how we are engaging with the public and patients at the moment at this early stage in the process, as well as throughout on our plans as they develop. So that's a bit of the context for what I wanted to talk through. I'm sure a lot of this is familiar to colleagues, but you'll know as part of the clinical futures strategy, that a big key sort of part of that proposal was the Grange Hospital, which opened in 2020, and saw a lot of changes for all hospitals within the patch, and no less so Neville Hall in terms of some changes to services. That was, and we've got lots of data and evidence to back it up, really important in assuring the sustainability and the quality of some key services, so stroke services, which were, as you'll know, consolidated there, all emergency care as well as paediatrics, obstetrics. So huge focus to deliver the Grange in 2020 in COVID. It did open early, and whilst there's been changes since its opening, we are now trying to make sure we get the balance right in focus, not just on that high-end acute end of services, but review and revisit our proposals for the enhanced local general hospitals. And also, important to note, our services out in the community, and I'm sure in future meetings we'll come back to talk about our plans around place-based care that we're working with colleagues on, our plans for the development and replacement of Dixon Road, which is, I know, is a key part of our strategic infrastructure plan. But for now, we're focusing on Neville Hall, and the challenges, they haven't really, they've changed in terms of we've shored up those acute services I touched on through the opening of the Grange, and we do see, if we look across Wales, many health boards still struggling with some of those services we consolidated in terms of sustainable configurations across sites. So whilst we've dealt with many of those, we still have some services that are under pressure in terms of workforce to sustainably respond to the demand at the levels of quality we want. We still have got further work to do to match the capacity of our services to the demand, and that's beds, but it's not only beds, it's workforce as well. We haven't necessarily got that all in the right place at the moment, recognising some of the challenges in the pipeline for workforce. And very much at the forefront of our minds at the moment is our ageing estate and the infrastructure challenges, and particularly RAC in Neville Hall. And nobody will be surprised to hear that we face financial challenges, as does the whole of the public sector, in terms of rising demand, rising costs, drugs, payroll, etc. So there's a number of challenges we're trying to square against the ambition of delivering high quality services for our population. So what we want to deliver hasn't necessarily changed since Clinical Futures in terms of sustainable services, matching capacity demand, delivering as much care as possible and is safe to do so closer to home. But really, when you need that high quality acute intervention, that's sustainable 24/7 and delivering the highest quality, and has a workforce and a pipeline for workforce that is assured into the future. And then on the right-hand side, some of the ways we're trying to do this. So I've touched on some care closer to home, working with GPs, wellbeing centres. I know not necessarily in Monmouthshire area, but in the north of Gwent, the new Bevan Health and Wellbeing Centre in Tredegar, a real kind of landmark development that we are continuing to work with local authority colleagues there in Blaenau Gwent on developing the services, integrated services with third sector colleagues as well. And there'll be lots of learning we can take from that model into other models across the rest of Gwent, and including the north of Gwent. And we do, as far as possible, want to organise ourselves as to limit and minimise travel, but we do recognise that is a key theme coming through our engagement and communication today, and I'll come back to that in a moment. So why are we focusing on Neville Hall? We have lots of other ELGHs in the patch that we need to review and do work on, but Neville Hall at the moment is our priority area for development, and helpfully, I think, Welsh Government, in terms of our relationship with them on investment, it's our joint priority, so Welsh Government recognise it as a priority for us and are keeping very close to us as these plans emerge and develop. So Neville Hall does and will remain a key site for us in terms of our service delivery, not just for the Gwent area, but for the region, for the South East region. And I'm sure I'll touch on it a few times this morning, but you can see that already through the opening of the new satellite, the radiotherapy unit in Neville Hall. That is a fantastic facility that's not just for Gwent and North Gwent populations, but also South Powys, the north of Cwmtaf Maganog. So it's a real regional facility, and we're really proud to have had that open on the Neville Hall site, sort of cementing our commitment to the site's future. The site does support a wide range of services. There's obviously MIU and assessment facilities, outpatients and day case, and we're continuing to increase the amount of surgery we do in Neville Hall at the moment. Through the work of some of our teams, we've managed to increase the amount of day surgery taking place at Neville Hall by 20% over the past year, so more and more patients able to have their day surgery at Neville Hall, whereas previously they probably had to go to the Gwent or YYF, so really trying to maximise the use of the facility. And just noting, it's really important, as I've touched on, to serve the wider communities as well. We've got some challenges. I think in terms of cutting to the chase of why Neville Hall as well, in terms of the RAC, and I'll come on to talk a bit more about RAC in the next slide. But as well as RAC, we know that since the advent of the Grange opening, the site hasn't been resized and kind of designed to map around the services that are now there. So sometimes, and if colleagues have been there, you can walk through maybe some empty departments or some wards are mothballed. So we do need to make sure we right size and design the estate there to match the services. And notwithstanding RAC, we still have challenges of estate. You may know we have challenges with the lift in Neville Hall. We've had lots of challenges in terms of the backlog maintenance. But the presence of RAC has brought it into sort of high focus at the moment. Hence needing quite a serious look at the future in terms of investment into the site. So just in case, I'm sure people have seen in the press over the last few years, public sector buildings, surveys and assessments of public sector buildings, because in some schools some issues with RAC were found. So we all have undertaken thorough assessments on all of our estate, and for us in Gwent, the presence of RAC in Neville Hall is not insignificant. What this is, it's a type of, I'm not an engineer by background, but what it is the way they used to build the concrete, has now found out to be not the most robust methodology, and therefore can pose risk. It's really important to stress, because we'll all have friends and family who are either work in Neville Hall, visit Neville Hall, or are patients in Neville Hall. We are working really closely with engineers who work across the whole of the UK, well, and Europe actually, to manage and mitigate the risks associated with RAC. And that's the place we are at the moment in terms of, you may see some propping, we'd have to do some additional work to make sure it's safe. So we have assurances through close working with Mott MacDonald, our partners, that the building is safe. But you'll see when you walk around there are props. So it's scaffolding in the middle to just provide that extra bit of mitigation, and that isn't an environment we want for patients, visitors, or our staff going forward. So we do need to positively respond to that through removing that risk entirely, rather than mitigating and managing it. The diagram on the right shows an aerial view of Neville Hall. So just to orientate, down here in the bottom right hand corner is that entrance that you come into Neville Hall, and then you come round to the car parks and the old front of the hospital here, and that's the education centre there. So these areas with the green blocks are where there is RAC. So essentially, all single-storey buildings with a flat roof have RAC, and the only areas from the main buildings, not the sort of outbuildings, without RAC are the 2H blocks, the towers where the wards are. So you can see that's not insignificant, and hence the reason for it being a big priority for us to respond to. And without sounding sort of, I don't know what the word is, but we need to address the RAC situation, and what we want to do is use the focus and the challenge that RAC gives us as an opportunity to attract investment. As I touched on earlier, whilst government are saying it's their priority as well, so this is an opportunity for us to get investment into Neville Hall, whereas, you know, candidly, did we not have RAC, Neville Hall would have been amongst many of the DGHs across Wales sort of fighting for investment. So RAC does bump it right up the list in terms of investment. So whilst, you know, no one wishes for RAC, we are going to use it as an opportunity to attract investment, because the RAC needs to be managed. And rather than move through those not insignificant areas, removing RAC and ending up with a building that's pretty much like it was before, but with no RAC, the opportunity is, well, let's look at right-sizing it, designing it to reflect the services there, best practice in terms of design, layout, flow for staff and patients, so that we get best value out of the investment it's going to require to remove the RAC, because this will be a significant investment required. And just moving on from RAC really, and again, just to restate the commitment to Neville Hall, there have been a number of changes since the Grange. We've established, I'm just going to draw out a few, recognising time. I've touched on the radiotherapy unit, so now patients with breast, prostate and on a palliative pathway can receive their treatment in Neville Hall. So they may not, you know, a patient from Abergavenny may not need to go to Velindre at all now if it's got those tumours, cancer from those tumour sites, which, you know, they're regular sessions you have if you get unfortunate to have to go through radiotherapy. So huge benefits for patients. Linked to that, we've relocated and invested into our own haematology day centre on the wards. We've also established, through investment from Welsh Government into Neville Hall, a regional cataract hub. So now we have theatres in Neville Hall using the old Llan Weneth Suite theatres, that and we have had revenue investment to employ additional surgeons to do cataracts, not just for Gwent patients, but for Cwmtaf, Meganwg and indeed some Cardiff patients as well. So again, kind of putting a bit of a marker in the sand of Neville Hall's future as a regional hub of strategic importance. And I've touched on earlier about the focus we're giving in terms of increasing day surgery activity in Neville Hall as well. Happy, Chair, to share these slides afterwards for reference, as I'm not going to read through every bullet point. I think I've touched on Velindre and its strategic importance. Again, beautiful facility, and this is really the start of this partnership, starting with those tumour sites I touched on, and whilst we're now open and patients are both having their radiotherapy planned and delivered in radiotherapy, we start delivered in Neville Hall. We start on the next phase of planning now in terms of future tumour sites, so patients can be repatriated from Neville Hall. So really exciting work on the back of just under £40 million capital investment into Neville Hall. So moving on in terms of where we are, and I appreciate this gets a bit jargony, I just think it is important to try and locate this work we're doing now in the context of the journey, really, we have to go on to get investment from Welsh Government. So I'm not familiar with the local authority processes, but we have to write business cases, develop business cases to outline the value for money proposition and get investment. And there are 3 stages to that business case process. I just wanted to touch, so we've got the strategic outline case, which is very early stages, identifying the case for change, doing some early work on engagement, early work on models of care, and testing what's called a proposed way forward. And that's really key then. When we get that supported by Welsh Government, it means they'll give us some money to go into the detailed development stage for the outline business case, which is the OBC, where we really do the really gritty and granular work on fully defining the models of care, the capacity, all the specs and the pathways, and fuller engagement or consultation. And then once that's approved, you move to the full business case, which again is testing the detail, affordability and the commercial arrangements. So we are here at the moment. So we are at the beginning. We're not starting with a blank sheet of paper because of all the work done previously across the Health Board over a number of years, but for the investment in Neville Hall, we're at the early stages, and that's why we're keen and are committed to talking to staff, stakeholders and communities throughout this process. So we are right at this stage at the moment, and we are engaging on the case for change. So some of the themes and areas I've talked about today in terms of the infrastructure challenges and some of the service and workforce challenges, the principles of what we want to move towards, and the emergent thinking, because we've obviously been working with colleagues in the organisation. So that's the purpose of the engagement. We don't have, and you'll come to see that, fully worked up propositions that we can present and are asking views on, because that's not real engagement. That's sort of asking everybody what we think once we've done the work in a sort of metaphoric dark room. But we're committed to iterating our thinking by working with colleagues. And then when we get to OBC, we move into more formal engagement and consultation on the firm proposals, and we continue to engage right through to FBC. So we're in this for a number of years together, and on engagement of the details of implementation, and we'll be working with whatever supply chain in the future as we move through. So I just wanted to sort of hang on that slide a bit to make the point of where we are in this process, being right at the beginning. I think I've touched on a number of these, and it might be time just to get into, so what is the emergent thinking? But just quickly to pick up things maybe I haven't picked up. So we are committed to a future of Neville Hall, not just for local strategic importance, but regional, building on the work done to date, linking it with, as far as possible, the work that's happening in communities through the place-based care agenda, developments in primary care. I'll come on in the next slide to talk about, so what are those services, what's the current thinking about services that we want to provide in Neville Hall, and I've already touched on the process for that investment. And you'll see in summary then underneath, these are the key drivers for change and the case for change that we'll be setting out in our strategic outline case. But I think I've covered most of those. So where is the thinking in terms of services gotten us? It's not just thinking. We've been looking at, obviously, our data, talking to our clinical teams, looking at and reviewing some of the thematics from our engagement that we did through our strategy work that many of you will have been involved with, and also the ongoing engagement. We have teams out engaging in communities every day of the week. So this sort of table summarises what the thinking is in terms of services on Neville Hall. So our ambition is to build on the work I touched on already around a day surgery and developing a day surgery centre of excellence and a hub for patients. There's now an accredited model The strategic importance of this in Neville Hall was also noted in a recent ministerial report. A ministerial advisory group recognised the importance of a surgical hub in this part of Wales, so where we can do as much as possible in day surgery, for general surgery, orthopaedics and ophthalmology, building on the cataract hub we've already developed. We are also testing and developing our model for the front door, so we know already GPs can refer patients, or they go into the flow centre and they can be triaged into Neville Hall, where they are assessed and if necessary admitted, or assessed and discharged. So we're calling it an integrated front door whilst we continue to do the work. So there is plans for an assessment facility to match the workforce and the size to match the needs of the population. We are doing a lot of work on analysing and auditing the nature of the patients and the needs of the patients who are coming into Neville Hall. And it may not surprise you that many of those are elderly and have frail and complex comorbidities that we don't think we've quite got the right workforce at the moment up there to match the needs of those patients. So that is work we're looking at already, to how can we best improve that, alongside the MIU facility that we are proposing remains there. We have a children's centre on site. We're not proposing that changes, and we know that there's work happening in the regional partnership board, so the RPB, that the Children and Young People's Partnership is looking at models of care for children with needs that visit the children's centre. And we're also, as part of this work, we're testing the feasibility, is probably sort of the language we use, on, so we've got Maendiff Court up in Neville, up in the Gwent region and the Abergavenny region as well, has not many clinical services, many clinical teams and many admin teams based there. And we are looking at the opportunity that the Neville Hall site might offer to improve their environment by bringing them onto the Neville Hall site as well. So helping us in our estate in terms of reducing the number of sites, but testing is one of the options we're looking at. So bringing the teams that are based there. We have 16 beds up in Maendiff as well. So that's part of some of the options we're looking at. And what benefits would that bring, not just for our estate portfolio, but for patients, aligning with some of the community services as well. So that's an option we are looking at as part of this process. I've touched on already cancer, so we have the radiotherapy service. We're keen to expand that. We're also keen to bring, working again with Velindre, on more chemotherapy back from Velindre. We've had some challenges in the Windsor Suite on Neville Hall in terms of RAC and its impact on service delivery. But this is an opportunity now for investment into Neville Hall and right-sizing the capacity we need for chemotherapy. That's the advanced anti-cancer therapy. That's what that really means there, is chemotherapy, where at the moment patients who have to travel to Velindre, how can we repatriate that back into Neville Hall? Outpatient services, one-stop shops, a key part of the model we're looking at, and how we can bring some of the learning. In the Royal Gwent, we developed and invested in an outpatient treatment unit, so taking patients and cases out of theatre if they didn't need to be, and it was safe to see them in more of a treatment room environment. That's really helped in terms of timeliness of treatment, and it's helped for us in terms of efficiency, in terms of throughput, and that's a model we'd like to see replicated in Neville Hall. A really important part of our offer there. There will be beds in Neville Hall, beds to support the patients coming in for assessment, and also beds to support the network that the Grange, in terms of the flow from the Grange into local communities. We have further work to do to make sure we model and get the right number of beds, recognising, as I said before, it's a key strategic part of our sort of network of hospitals. Another new development we're looking at for Neville Hall is a women's health hub. It's a priority as part of the current programme for government in terms of the development of a women's health hub, one in each health board area. and this work is led for us by our Director of Public Health, Tracy Daskowitz, and the work that's happened through that work stream identifies Neville Hall as the optimum place to place that Women's Health Hub. So again, an exciting development to bring onto the site. Closer to the female population in terms of density and where that would best benefit, and a range of diagnostic services. So we already have a really good range of diagnostic services in Neville Hall, and this work commits us to keeping them there, probably doing some work to redesign them in terms of making them work more effectively in the flows, because they're a bit disparate at the moment. But this work absolutely sees a strong future for them on site. With therapies as well, we have therapy services in a number of areas, and we are already working with other partners and across some of our other sites to review our model for outpatient therapy services. And obviously inpatient therapy services would need to be on site to support the inpatients, reflecting sort of the needs and the nature of patients there. So that is, in terms of the model we're seeking to develop, embed and or enhance in Neville Hall as we go forward. We think it's sort of an exciting proposition, sees services coming to Neville Hall, and also those that are there being made more sustainable. I'll just finish the last few slides and then invite Dr. Misen if there's anything he wants to add on these sort of key areas. But as I touched on in my slide on the process we're in, we are committed to involving patients and the public. We've worked really closely with Llais on the engagement process and design of the process we're in at the moment. So we've already done a lot of engagement through our work on our strategy development that we've are feeding into this Neville Hall specific work at the moment. We also look at, as I said, we're already and always out and about our engagement team. We're using the themes and the feedback from there. We know some of those are communication and transport challenges, which are sort of ever present really as we try to sort of improve services. We are in a engagement at the moment on the case for change, as I've set out. We use a different slide deck just to reassure you when we're out with public and communities that's tailored and being tested. But the purpose of this, as I said before, is to really kind of get engagement and understanding of why we're doing this work, and why Neville Hall and why now, but also on some of those principles and emerging thinking to get some honest feedback. And then we'll move into, as we finalise the SOC, the strategic outline case, and get into granular planning for our outline business case, that commitment to carry on with the detailed engagement. So we are, well, I think we're just about halfway through the current engagement plan. We are using a number of methodologies in terms of going out, meeting people, encouraging, and anything you can do to help us, we'd be really grateful. Feedback of our online survey, which we're pushing through many of the networks we developed as part of the strategy work. Going out and visiting teams that we develop those networks through that work, going to a number of meetings. I'll share some of the schedules, and also using social media as well to get feedback. So really important, and that close working with Llais. We're asking some kind of open-ended questions. We don't want to be too close because we do appreciate, and it's really hard actually, because some people respond to this and in recognition of we're at the start of this. We haven't got fully worked up propositions because we want to engage meaningfully, but that sometimes people are like, well, what are you asking us? So we're in that. We're just working through that at the moment, and that's just the reality really of which we've learned over the years in terms of engagement. So open-ended questions to try to get some deep feedback from partners and staff and patients and communities. We've got a schedule of meetings across obviously the Abergavenny and Monmouth area, but recognising that flows into Neville Hall don't just happen from the Monmouthshire and the area. We've got flows in to services from a number of areas. So we do, as agreed with Llais, need to spread our engagement across the whole of the patch. So I think that was really all I was going to say before inviting Dr. Meisen if I missed anything specifically. But as I said, we've got a number of ways for engagement, and we're actually getting quite a few direct emails into the team as well, which we're more than happy to take, as well as more than happy to come out to specific groups. I was in the Abergavenny Civic Society a couple of weeks ago, so as well as these open events, we are keen to go to local groups as well, if and when they ask. So I will hand over to Dr. Meisen in case he wants to add anything to the areas I've covered, or we can move to questions.
Very briefly, really, that's very comprehensive. Thank you very much, Hannah. That was fantastic. Just to say, it's been quite a pleasure getting out and about into the communities, sort of listening and talking to people, getting their views on this, and yeah, we're getting a lot of useful feedback.
Dr. Meisen, sorry, Dr. Meisen, sorry to cut across you. We can't. Can we see you on the? Sorry, is that the?
If we take the slides down.
Oh, we need to take the slides down. Lovely. And could you just get your volume up a little bit on your microphone, please?
On your laptop.
On your laptop.
Yeah.
Thank you.
Can you hear me now?
Perfect. Thank you. Sorry.
I was saying that it's been a pleasure getting out and about into the communities and sort of listening and sort of working with these guys to help shape these services. Real opportunity for us. We know with the Grange that we've got quite a few benefits out of that. We've stabilised a lot of the services, and for the care of the very unwell patients, the Grange is a great place. It's perhaps not so great for those patients who aren't critically unwell, and part of what we're doing with getting our services right, including Neville Hall here, is making sure that everybody gets the right and best care. It's very, very good opportunity for us to start to shape that both in estate and staff. But this is really the very early part of the consultation. There's nothing written in stone, and that's why we're here, to listen to feedback and to work together on it.
Thank you, Dr. Meisen. So I didn't call you Dr. Meisen to begin with. I'm from a generation where my parents would have expected I called you doctor, just out of deference, really. So right, we're going to move to questions. I see then you've got Councillor Edwards has got his hand up first. This is like a super group of councillors here this morning, isn't it? So Chris is going to go first. I'm going to try my work through the people in this room first, and then I'm going to open it up. And then I can see, look, Jill straight up there with she's got three hands up. Well done. And then we've got Maureen in the north there. I can see from the background of your photo there, you're in the north, Maureen. So I'm going to go with Chris first. Chris.
Thank you very much, Chair, and thank you, Dr. Meisen and Hannah, for taking us through that presentation. I really appreciate the update today on where you find yourselves as a health board. When I first read the briefing document, I wondered who instigated it, whether it was the health board itself or Welsh Government, and why. Although, either way, as you admit, the report will be produced and will also prepare an investment case for the Welsh Government to consider. The second thing I wondered, what future possibilities there will be, or at least realistically be, at Neville Hall. And I'm somewhat concerned that the briefing paper and current public consultation gives the impression that when it comes to discussion, nothing is off the table, which in one way is great news. However, in reality, with the demands on the NHS being as they are, do you think that the document is misleading the general public a little, especially under the section on what might the future Neville Hall Hospital look like? I mean, personally, I think you've tried your best as an organisation in trying to educate the public in the modern differences between the hospitals in Monmouthshire and what they do. This process may sadly lead to more confusion, though. Despite people's wish lists, what inpatient specialist services will realistically be available at Neville Hall? At the moment, there's no respiratory, no gastroenterology, and no cardiology. Much needed specialisms with people of a certain age, and we have plenty of those in Monmouthshire. On the other end of the spectrum, what paediatric services will be available? There are no paediatric beds at the moment, and all patients that find themselves in need of this specialism go straight to the Grange. And it was only just over a year ago that the minor injuries unit hours in Abergavenny were reduced to 18 hours. Understandable in the circumstances of data available, but still left people angry and confused in Monmouthshire. So, from what I understand, chemotherapy is only provided at the Balindra Cancer Centre for certain cancers. Radiotherapy is the only treatment given at the new unit at Neville Hall, although haematology cancer is treated at the Grange. As you can tell, I'm a little cynical and only trying to be a constructive friend, having spent my short years as a councillor trying to help and support residents on local issues, while also trying to manage their expectations. And how can we do that with this, in managing their expectations on what the future of Neville Hall will be? Having been someone who has promoted this consultation, I guess I'm also asking for advice on what reassurances we can give residents in the 2 weeks left of the consultation that their views, although probably mainly one of a service user rather than a professional, that their views would make a real difference. As a lot of talk has been mentioned about cancer treatment, and obviously it's part reliant on community fundraisers these days by many amazing organisations, many of them well established. I imagine the funding is often taken for granted. Will that still be the case if this enhanced local general hospital programme goes ahead in the current guise? Will it still have it be heavily relied on community fundraising? And just to close, I'll never forgive myself if I don't finally close with one more question. I appreciate that today is about Neville Hall and its future. However, I know that Chepstow Town Councillors and County Councillors, including myself, have always taken a great interest in the future of Chepstow Community Council. Now, I appreciate that the Health Board was handed over responsibility, operation responsibility, that is, for the hospital when the PFI agreement came to an end in March of this year. And I'm sure we'd all be grateful if you can confirm if a similar development plan or public consultation is planned by the Health Board for hospitals like the community hospital in Chepstow in the near future, or is it a case of you're going to incorporate the findings of this process into hospitals of that size and use? I mean, there was plenty of praise for its clinical teams, its facilities and future at the time by Mr Marchand, Director of Estates and Facilities at the Health Board. And hopefully you can find the time today just to update us a little bit on that as to how it sees itself as part of this plan. Thank you very much.
Great questions, Chris.
Okay, I've been scribbling them down, so I'll start and I'll bring Paul, Dr. Meisen in as. So in terms of who instigated this, I guess the Health Board did, working with Welsh Government on the back of the, for it to happen now, on the back of the RAC developments. We have an estate strategy, we have, and the development of Neville Hall has always been on there, and I'll come back to the Chepstow point as well, because that's obviously a key part of our estate. But the thing that ramped it up the priority list in terms of investment and focus is the presence of RAC. So it was always on our kind of to-do list in terms of the development of ELGHs post the Grange. We've done some bits of work already on other ELGHs in terms of there's been some developments, new endoscopy suite at the Royal Gwent, development of an R&D facility at the Gwent. We've done the diabetes centre in Neville Hall, but it was the RAC really that made us take a much bigger and helpfully shone a light on it to give it a strategic focus. In terms of some of your questions then around the services, I guess an important point to make is that we will not, through this process, be bringing back specialties, acute specialties from the Grange to Neville Hall. Part of, and Dr. Meisen touched on it, part of the reason we had to do the Grange was because we could not sustain those services across a number of sites just simply didn't have the workforce or indeed the critical mass of patients to either sustain them to deliver the right quality. So we will not be disbanding those rotas, in terms of acute cardiology, gastro and paediatrics. For those cases, those pathways will remain, and we won't be undoing them as part of this. What we will be seeking to do, though, is those services where it's not an emergency. So paediatric outpatients, the children's centre, for example, and other outpatients, so cardiology outpatients, gastro outpatients, endoscopy, which falls under the umbrella of gastroenterology being provided there. So within a service, there are some elements that need to and will continue to be provided from the Grange, and where it's appropriate and we can, and that's the detailed work that quite rightly everybody wants to know the answer to now, but we get to that as we move through the process. Will be sort of determine the detail of which outpatients exactly and which subspecialty of patients will be seen in either a clinic or in a treatment centre. Just quickly on cancer, and I'll invite Dr. Meisen to come in. So we've talked about radiotherapy quite a lot, the new unit. We do already have chemotherapy in the Windsor suite from Velindre. We're just doing some we're going to be moving them to a more appropriate environment, and we want to increase both of those. So we want to do more chemotherapy and more radiotherapy. So that's an increase, working with Velindre, of cancer services into Neville Hall. So I didn't want to lose that point as well. In terms of reassurances that views will make a difference, I guess that's I think that's the role of SLICE. We've designed the process with them. They will be alongside us in this and kind of holding the mirror up to us and sharing with you and other stakeholders in terms of the feedback and our response to the feedback. So there's some independent kind of check then in terms of the response and the reassurances I can give there. And then finally on Chepstow, again, we have a state strategy, and Chepstow has got again a future in our configuration of services as we move forward. Indeed, as you touched on, Councillor, we've recently bought the PFI out, so that facility, we're not in a PFI arrangement anymore, and we're actually look at Chepstow and the models of care that are developed there. And we're looking to spread those into other areas across the whole of Gwent. So Chepstow is kind of is firmly rooted in our plans for the future. And I did just want to touch on Monovale as well. Monovale, we are keen to develop and embed and do more services, working with local authority colleagues in Monovale as we move forward into getting into we call it the place-based care model, so centering services around communities. So both of those sites in the Monmouthshire area have key sort of strategic prominence for us as we move forward. Dr. Meisen, did you want to come in on any of those service-specific areas that were raised?
A couple. I'll start with the radiotherapy centre, which is obviously a recently opened. The benefits of the reduction of travel for these patients who are travelling sometimes on a daily basis for a number of weeks to Cardiff for the really important treatment. That reduction in that journey is really very significant and is a massive step forward. We want to do more on that site. And I'm sure that through this that we will. With regard to the centralisation of acute specialties, when we look at objective measurements of outcomes, and particularly a standardised adjusted mortality, the Grange has been a great success. It's very, very good at looking after very unwell patients because we have critical mass of clinicians that are able to staff areas such as respiratory high care. We're able to get pretty much instantaneous access to emergent endoscopy. So the centralisation of all the services, as well as making them sustainable from a staffing perspective, have given us real results in terms of outcomes. we wouldn't want to be looking to roll back on that. Part of this is right-sizing the role of Neville Hall within that whole system. We would like to be able to assess and if necessary in the Grange, and then people would complete their care in Neville Hall as needed. Plus using that sort of integrated front door as a bridge into our community services, so that people can get care closer to home as much as possible. So this is as much about organising and integrating our services as it is about the buildings, and taking the opportunity for investment to right size and right shape our care. I think that covers the sort of clinical models aspect I wanted to cover. Thank you.
Yeah, no, thank you for that, Chris. You asked some really interesting questions, and I'm happy to allow members to broaden this out. Chris is, for anybody that's not come along to our scrutiny committee before, that's a good example, I say, of a good opening question, if you don't mind me saying, Chris. I know it's a bit early for compliments, isn't it? So, but have you got any secondary or supplementary questions?
Just the one point, that's all. Well, maybe two. I've got a little bit of a confession, actually. When I've tried to go onto the survey on a couple of occasions, it's crashed. So one thing I was concerned about, and by the way, I completely agree with you about acute specialities remaining at the Grange, but I'm more concerned about sort of managing expectations of residents. So when you go into the survey, does it actually outline what will be achieved? In other words, if people ask for certain things, they're not necessarily going to be, fulfilled. So are people's expectations realised when you go into the survey and complete it? And my second point was that you mentioned about Chepstow and Monovale. So will they be looked at as part of this programme, or is that completely separate?
Okay, so one, you probably saw me grimace when you said the survey crashed, so I'll pick that up. If that's happening, that is really not acceptable, and we'll pick that up, and it will have linked to the information. I really appreciate your point about managing expectations, because that is the sort of balance we try to tread. Sometimes we may get it right, sometimes we may not, in terms of giving assurances that Neville Hall forms a key part of the future for our provision and our configuration of service delivery. But this work, as I said, it won't undo some of the acute changes we've made. And as we go through the detail, some of the changes will crystallise, and we could get to a point further down the process, those steps that I talked through, where we're talking about some services that we need to think about configuration. What we're trying to do is give assurance that there's a huge suite of services whose future is I never like to use the word secure or fixed, because that's sort of a dangerous word in kind of, when things change. But our ambition is to retain those in Neville Hall. And hopefully you've seen our ambition is to add more as well to the Neville Hall offer, whether it be regional services or I talked about outpatient treatment unit. So it is a line we try to get right, that managing expectation that this will not be a return to Neville Hall of pre-Grange with all those services, because if we could have sustained that, we wouldn't have needed to build the Grange, and we know there's been challenges as well as opportunities along the way. So really keen, if we haven't quite got that right, and you're saying there, and through some of the information there is still some of that lack of clarity, we need to pick that up as we move forward in our engagement. And very practically we'll pick up the survey bit. I'll frantically send an email whilst we're on this call. In terms of Chepstow and Monovale, they are not part of this project now. They are part of our wider strategy, but they're not part of this project. We have other, so Neville Hall is our sort of number one estates priority. Our second is Singwellis, which is in the south part of the county, and we have huge estate challenges on that site as well that we need to address for the services and the staff and any visitors still accessing there. So this year we will review our estate strategy. That won't change the work we're doing on Neville Hall. But whilst Chepstow we look at services and developing the services, there's not a big estate investment planned for it when you compare it to some of the other sites. And Monavale we are looking at alongside the development of primary and community services more generally, working with local authority, with some of your officer colleagues.
Thank you, Hannah. I'm sure the survey issue is probably just down to the number of users using it, I expect. Thank you.
I hope so.
Thank you.
Find out quickly.
Right, no, thank you, Chris. Maureen, I'm just going to say this. We've got Hannah, I think, for at least another 30 minutes. So I'm going to be very hot on any potential duplication or rambling, which I'm guilty of myself. So I will not ramble as long as you promise not to ramble. Maureen never rambles. Okay, so Maureen.
Thank you, Chairman. Thank you very much for the presentation this morning. It's been very thorough and very interesting. It's going to be great not having to travel all that way down. About a few years ago now, I was taking my husband 5 days a week for 5 weeks, all the way down to Velindre and back every afternoon, and it was quite exacting. My question really is, when you at the moment, there's quite a lot of ceiling supports in the corridors as I've been attending the hospital recently. How much effect will this have on the areas there when they are dealt with and removed? Will it close those parts down, or will they be able to continue? Thank you.
Thanks, Councillor Powell. So just I'll heed your warning too, Councillor Watts, in terms of trying to be concise in response. So yeah, great. It's nice to hear in terms of the welcoming the radiotherapy changes. As I said, and just to reiterate, at the moment it's only those 2 tumour sites of breast and prostate patients, but with an ambition to expand further. Those struts that we have at the moment, we are trying to, as far as possible, remove them and doing some work, but we don't want to do a lot of abortive costs in terms of spending a lot of money to get rid of the struts for an area that may be repurposed in the future. Some of that is going to come through in the detail, is the honest answer, in terms of will those areas be closed down. We may have to do some interim changes like we have had to with the Windsor suite in moving chemotherapy patients, but the detailed planning and sort of logistics of that is something we're just not into yet. But what we can just assure is, working with our engineer colleagues, Motts MacDonald, we are on a 2-weekly cycle of checking the mitigations we've got in place to make sure they remain sort of fit for purpose, and reviewing any new guidance. So some of that detail will come out. We don't have yet, is the honest answer.
Thank you very much.
Thank you. Right, so we've got Jan.
Thank you, Chair, and thank you, Hannah and Paul. Great presentations. It sounds like we're at the early stages of some very exciting developments, so really good reports. I have a couple of sort of immediate questions, and this might be straying a bit. The current situation, you have mentioned this already. There is only one lift working at Neville Hall at the moment, and there's no staircase that actually goes with that lift. And you have about a quarter of a mile walk if you want to find the actual stair lift. So it's causing massive queues in the stairwell. I'm telling you something you already know probably. And then you're having about a dozen people in the lift, and a lot of these patients are haematology patients with very vulnerable immune systems. So it's far from ideal. So I'm just wondering whether there are any mitigations planned in the short term to resolve that, because it's really unsatisfactory at the moment. And as I say, I'm sure that you actually know that. My second question is, this relates to the overnight closures at minor injuries. Has this actually impacted on the Grange? Is it putting pressure on the Grange? And I know there were a lot of concerns about staff being de-skilled as a consequence. Can you just bring us up to date on those 2 items, please? Thank you.
Okay, thanks for your question. On the first one, we are not waiting to resolve RAC to sort the lifts out, so that's a commitment. And if I think somebody already mentioned that Jamie Marchant has been to maybe this meeting before, so sorting those lifts out is a priority, and we've got plans in place to do that. We're also relocating the assessment. Relocating some services to mitigate the use of the lifts as well, because ultimately they're old lifts and they need repairing more and more frequently at the moment, as you've touched on. So absolutely, it's quite high on our kind of radar and risk register. MIU, we track the impact of that, and we haven't seen a negative. I'm sure there will be stories of patients patients who've been redirected, but in terms of numbers, we're not seeing a big impact on the Grange in terms of that overnight adjustment of hours. And the staffing, they're managed, the teams and the workforce are managed. It's one team, so they do rotate through as far as possible, and we do still have the consultants rotating through MIUs as well in terms of skills, practice, and any quality and clinical governance oversight.
Thank you. That's very useful. Those are two positive answers. Thank you.
Yeah. So I'm now going to bring in Jill. Jill, there's confusion on the. So you've got 5 hands up. You had 6 and then removed. So I've just moved you back one. So I'm not going to waffle on any further. This is your opportunity to fire off a couple of excellent questions. Thank you.
Thank you very much. Thank you, Chair. Thank you for the presentation and your plans for extensive consultation, and welcome this opportunity that you're taking for efficiency and effectiveness and right sizing, which I think is fantastic. I'm also a member of LICE, and I wonder I just wanted to know when you're anticipating coming back to LICE to look at decide on the preferred option. Thank you.
Thank you. Thanks, Jill. I'm just checking something for a date rather than anything else on my phone, if colleagues were wondering. So we've got a midpoint review with LICE. I think colleagues met with Lisa on Friday. I was at the office on Friday in terms of reviewing where we are, and that engagement in terms of testing, especially if there's been challenges, and I need to pick up, has that been a theme in terms of challenges of accessing the survey? Because if so, we will, and we'll need to extend the engagement to make sure it's proper and fair. We touch base with Lisa. We've got a fortnightly basis now in terms of tracking the themes coming through. So in the spirit of sort of no surprises when it concludes. And LICE will, as you will know, will do their own report as well. So we'll have a report for the themes, but LICE will do that to provide to us and others for sort of that independence. So we're due to end, subject to LICE agreement, that week of the 12th of August, and we'll have a report then following that. So it's difficult, isn't it, with the sort of summer season, but I imagine the week after that or 2 weeks after that we'll have a report from LICE on the outcome. It will then go into all the other work streams that are happening as part of finalisation of the strategic outline case. Capital costs we need to look at. We're working at some assumptions and high-level analysis on revenue costs as well. So all of that insight and intelligence needs to come together for the business case to be finalised, which in terms of, I haven't mentioned this, but at the moment the business case is the plan is to take it to the Health Board in September. But subject to the outcome, we're still in the process of sort of finalising it. So that's the plan, and then on to Welsh Government for endorsement.
Chair, sorry. Was that the OBC or the FBC you're saying?
The strategic outline case, the first, the SOC. Oh, we love an acronym, don't we? So the SOC is the bit we're working on now, that first phase, and our intent is to take that to our board in September. There will then be, the standard is 3 months for Welsh Government to come back to us. It depends, doesn't it? We go into quite interesting sort of season politically, so whether we get a response in 3 months, whether it's shorter or whether it's longer, remains to be seen, really.
Are you saying start mid-late 2026, are you?
Start what? The OBC development then will start late this year. OBC development. We are not going to be looking to be. Let me just check these dates. We've got so many sort of hoops to go through. Our FBC, we wouldn't be finalising that, so we wouldn't be looking to. We wouldn't have sort of what's the expression? Diggers in the sand until 27, 28. It's not sand, is it? But so it's a bad expression. But because of all of those business case processes and additional work we've got to do, that's unfortunately the sort of time it takes.
Okay, thank you.
Thank you, Hannah. I've just got a horrible feeling that might be the headline in the Argus tonight, Diggers in the Sand, Hannah. Sue?
Yeah, probably, yeah. That wasn't a great expression, was it? But that's, if we follow the timelines, that's when we would be looking to commence in earnest development. But I will reiterate again, there are many gateways to go through in terms of satisfying the health board that it's a case that stacks up. You know, the health board needs to consider this in September, then satisfying Welsh Government, and then moving through those other gateways in terms of the OBC and FBC. So there's a long way to go. And one thing I probably can predict is that these timescales will change as we move through and things iterate as we move through those gateways.
Councillor Riley.
Thank you, Chair. And thank you both. I guess I'm interested in the numbers. I think the reduction of travel for radiotherapy is enormously helpful. I'm just wondering whether we're looking at quantity rather than quality, based on, do you know how many secondary cancer sufferers there are in Aneurin and Bevan? Because I'm aware Welsh Government don't have any data on those secondary cancer sufferers in Wales. I had to go through some very specialist radiotherapy called SABRE, which was hugely debilitating, but I just wondered if things like that were going to be available in Aneurin Bevan, and I'm wondering what other services for secondary cancer sufferers, because there isn't very much available locally, that you will be hoping to put in place. Thank you.
Thank you, sir.
So I haven't got the figures of the numbers. Happy to take that away and try and follow that up if that would be helpful. I think whilst we've got a joint ambition with Velindre to repatriate as much as possible, there will be some limitations in terms of complexity. So complex radiotherapy will still take place at Velindre. That's sort of driven by, you know, specialist expertise and equipment. Just on the terms of quantity or quality, just to give assurance, the staff at Velindre, a bit like I touched on the model that we do with MIUs, they are, whilst there's site and unit management, you know, bespoke and dedicated management, the staff will rotate through so that, again, they maintain their services, they maintain their skills in line with developments at the current Velindre Cancer Centre and the new, obviously there's a new Velindre Cancer Centre in development as well in Cardiff. So the staff will rotate through, and it's one of the principles of that project is that for the pathways that go to the radiotherapy centre in Neville Hall, it's the same standard of care, the same access to advice and support, whether that be through therapy support, psychology support. There's also an offer like a welfare and Maggie's outreach we have now up in Neville Hall. So it will not be the full suite of Velindre services, but it will certainly be, and again, I can confirm the numbers, a large swathe of patients who would otherwise have had to travel to Velindre.
Can I just come back on that, Chair, please? I guess what my main purpose of that question was, it seems that the sickest people have to travel the furthest. And what I also would like to add about Maggie's is it's 2 hours once a month, and it doesn't really cater for secondary cancer sufferers.
Yeah. Yeah, I appreciate that we are working on extending and expanding the Maggie's coverage, obviously with Maggie's, I hear your point around the sickest needing to travel, but we just don't have in terms of with Felindra as well, the expertise to put that into Neville Hall as well. But this is the start of our partnership journey with Felindra in the new facilities. So we do need to try to make sure we focus on delivering the commitments of the full business case for that project, and whilst looking at further opportunities. It would be remiss of me to commit to those, especially with Felindra patients, to commit to some of those more specialist cases being repatriated at this stage in our development. That's not currently on the plans, but I recognise and hear your comments in terms of the sickest still travelling.
Thank you.
Thank you, Sue. Thank you. We've now got Councillor Howells, and then we've got Councillor Brown.
Thank you, Chair. Thanks, Hannah and Paul. For these, it's good to hear these improvements here proposed for Neville Hall. Sorry, I think Councillor Bond has already asked one of my questions with regards. I think the word you were after was a spade in the ground, commencement of 2027, 2028.
Don't spoil it, because you've just thrown ahead.
Fingers in the sand is a new word. How you started.
Thank you for saving me there.
I was just also wondering how staffing shortages will be resolved or improved in this new model, and also I might have missed it, but what is the plan and timeline for removing and repairing the rack concrete at Neville Hall, and will services be disrupted during this work? Thanks.
Okay, so in terms of, I'm going to take the last question first, because I just want to check my understanding of the first question. So in terms of RAC timeline, we won't be removing RAC until we do the new build, the big investment, and that's why we're taking the opportunity, because removal of RAC itself is not an insignificant amount of investment. So we want to make sure that when we're doing that, we're improving generally the offer and the environment. So between now and us doing a new build, because the thinking, again, we haven't finished the outline case, but is that we develop and retain those two tower blocks in that H shape. We retain those, and we rebuild a new building rather than go through all those areas I showed with the green blocks or the shaded out blocks on top. Rather than go through all of those, the thinking, again, to be tested and supported through those investment gateways, is to retain the two H blocks and do a new build, so that it's actually, we think, again, we're in the middle of the process, we think that may demonstrate more value for money. Up until that point, as I said previously, we continue to work with our experts on fortnightly check-in of all areas with RAC to ensure safety and that services can continue. We may need to do some interim changes to services in terms of relocate them on site. We've already had to do a bit of that with the Windsor Suite. Yeah. But that will, as and if new guidance emerges in terms of the management of RAC and the risks of RAC. So there's this, I say long-term plan, there's the big plan in terms of the investment, and that does sit alongside the operational day-to-day, week-to-week management and monitoring of the situation. And if things change, then we will, of course, communicate that and link with yourselves and Slice and other colleagues. On the staffing shortages, can I just check, all I wrote down was staffing shortages in terms of question. Was the question, how will the proposals mitigate those staffing shortages? Can I just check?
Yeah, that's it. Just to sort of, how will they be improved or resolved?
Yeah. So so some of the changes, we talked about a number of different areas of services. We've got live work at the moment in terms of projects and programs of improvement on outpatients. They're quite specific depending on the service you talk about. So, for example, endoscopy, Dr. Meisen's specialty, there's an awful lot of work on the skill mix of clinicians who provide the endoscopy service. So, I keep using, because he's a gastroenterologist, there'll be doctors who undertake endoscopy, but we're now developing nurse endoscopists to be able to provide those procedures where possible. We're also looking at other technology that can help with some of the staffing challenges, different ways of delivering endoscopy, so that's a good example. I might leave Dr. Meisen to go into the technical, but transnasal endoscopy, capsule colonoscopy. So we're using both technology and skill mix to make sure that we can sustain going forward. Where we have the biggest challenges in some of our medical staffing is my point about where we need to look at the assessment, the patients who need to come to Neville Hall for assessment, and making sure that we look at the staff that are required to assess. So at the moment we have acute physicians assessing patients, whereas if our work shows us that actually those patients' needs are more frail and complex comorbidities, then we might need to look at a different workforce that isn't an acute physician. So appreciate that's a bit of a sort of multi-layered answer, but it is quite service specific in terms of what the workforce and what the workforce responses will need to be. And from I mentioned, so Velindre is a rotational workforce anyway. We're obviously working towards that with our surgical specialties as well. So we'll have surgeons who work both at the Grange and at Neville Hall. So that, in terms of how we cover, that sort of model we'll be looking at. And indeed, the regional work is attracting workforce. So building a vision and articulating the future for Neville Hall, it's not unreasonable to suggest that then can contribute towards attracting staff. When our work and the Granger showed that having that model, having that vision, has attracted staff in those specialties to work in Gwent, and so therefore it's not unreasonable to assume that will happen in Neville Hall as well when we sort of finalise and get final agreement of these investment cases. So we take it on quite a service-specific basis on the workforce. Paul, did you want to add anything on that?
No. Sorry. So we literally have. So I'm going to intervene here. So I do apologise, Hannah. You're on such a roll, and I want to let you. By 12 o'clock. I have got. This is an almost impossible. So we have got 11 o'clock even. Sorry. So we've got. Think about this now. Think if you imagine you were me. I've got the two cabinet members, and then the last person I've got is Louise. So I've got Louise and the two cabinet members, and I've got to summarise in 8 minutes.
Okay.
Sorry, Louise. Yes, I am. I'm sorry.
Yeah, I'm going to try and be as quick as I can. On the building itself, are you going to put on the roofs? Are you going to put solar panels? And I think it's good news for the Abergavenny Neville Hall. The other issue is I'm so pleased that you're changing your priorities in terms of putting local as a priority, and Judith Padgett said it was all about specialised, centralising services, and I'm very glad you've listened to the feedback. I'd just like to ask about whether we could have another seminar on the Royal Gwent and the local hospitals and what's going on there to localise the services. And being a Chepstow member, I can't help but plug the fact that we'd love a minor injuries unit at Chepstow, in view of the fact that the population of Abergavenny is about 10,000 and the population of Chepstow is nearly 12,000. And I've also got concerns about the accident and emergency, the Grange, and how minor injuries units work, because I think that people often don't know which one to go to. Thank you.
Thank you, Louise. Appreciate that.
Okay, so solar panels, we haven't designed anything yet, so but the decarb agenda, we absolutely want to and have to respond to that as part of the arrangements we have with Welsh Government. So whether that will be a feature or another way of satisfying the decarb and the net zero agenda, that remains to be seen. We haven't done that work yet. So Royal Gwent, Chepstow and A&E in the Grange. I could have another session on probably need another session on that to pick those areas up. We do have what Neville Hall, I've said already, Neville Hall and St Woolas are our estate strategic priorities. We are not at this point, and we are not planning to put MIUs back into Chepstow. I appreciate the comment about the population levels, but it's not just Abergavenny that flows into Neville Hall in terms of the MIU. We take the catchment area is much broader than the Abergavenny, but it's not a live discussion or something we're pursuing at the moment in terms of reintroducing MIU into Chepstow. Yeah, I just need to be honest on that one in terms of where we are. Happy to come back and talk about plans for other ELGHs at an appropriate time, including the Grange. I'm sorry, including the Royal Gwent.
Yeah, and local hospitals. Yeah. Community ones. Thank you.
So just brief, just in a quick. So this is a topic that's come up, isn't it, Chepstow? The changes post PFI. From March, so we're all concerned about that. Chris has raised points about it. Louise, myself, Jackie, everybody really in the south, isn't it? So what we could do is have a separate meeting and invite Anara and Bevan along to come and talk about some of the changes that are going to happen in the south in the future. Steve, I do apologise. You came up last on the. If you've got a quick cheeky question, and by all means, fire away.
Yeah, I put my hand down when I realised we were against so close. It was just really a plea to those of us in the kind of northeast of the area, Monmouth, because we are a little bit out on a limb. It's good to hear about Monivale being prioritised as well. But just kind of don't forget us. We things like vaccinations. I've had to take my boys all around the health board area to get to Evervale and Pontypool. So if we can get more local things like COVID vaccinations, boosters and that done locally, that would be great. But Monivale encouraged about that and hope that will become a much higher priority place and more services available there. Thank you.
Thank you, Steve. I'm not sure. Is that a question or is that just a comment, really, isn't it? Sarah, we've got you up next.
Just an observation and comment, yeah. Thank you.
Thank you, Chair. And unless you want me to take my questions offline and allow Councillor Chandler to come in and...
Sorry, can you repeat that?
Unless you want me to take my questions offline with Hannah and allow Councillor Chandler to close.
Yes, if you wouldn't mind, that's really helpful. Thank you.
Okay, thanks, Sarah. That's good. And if you want me to come in, that would be great. So first of all, thanks, Armand and Jackie, for hosting this meeting, because I think it's really important that we got to hear some of the details of the proposals here. So just a few comments and maybe a question that I might follow up afterwards. Just for first comment, I just think it's really positive to hear that there is a long-term commitment to Neville Hall as both as a local community hospital but also as a regional centre, and I think that is something that is really reassuring for us and for residents. And I think in terms of that regional centre, it's really good that it particularly matches our population profile in terms of an older population, that there's going to be specialisms with orthopaedics and with ophthalmology and cataract surgery. So I think that's good. It's very positive, I think, also that you're engaging with the communities and with us and stakeholders at a very early stage in the thinking, and I look forward to seeing how the thinking develops over time. I suppose I've got a sort of maybe some questions that not necessarily if you do answer now, but to reflect on, and maybe we have a follow-up conversation. It's about seeing these proposals as part of the broader health system, because I think it's so hard just to look at a hospital site when we're not looking at how that interacts in terms of public health, primary care, preventative work, how the overlap is with social care as a part of the broader health and social care system. So I think I would welcome an opportunity maybe to have a little bit more sort of conversation about that. And also how it fits in with things like the out-of-hours GP service that operates from Neville Hall and all those other types of things there. I've also got a question about the overall context that you talked about in terms of reducing the number of beds. You've got too many beds, but that's sort of, how does that reducing the number of beds going to impact on waiting lists, both for acute and elective surgeries and things like that? So I have both a few questions around that. Other comments that I wouldn't mind making at another stage. I mean, issues around diagnostics I think is really good, but if we can really get that preventative diagnostic agenda forward, and as Steve Garrett said about, more of some of the, the vaccination work and other types of things would be good. Anyway, but that's probably enough for me. But thanks ever so much for coming in and talking about those things, and I'd look forward to following up with you later, Hannah, and Paul as well. Thanks.
No, thank you, Ian. Thank you. Hannah, do you want to just come back? I know you're literally the clock is ticking seconds away. Then I'm going to be really polite and ask. I do apologise, Paul, for cutting you off. So I'm going to, once you've gone, I'm going to bring Paul in, and then we'll wrap it up then.
Yeah, thanks. I'm happy to pick up with Councillor Chandler offline, but absolutely. How Neville Hall, it's not an island, is it? How it fits within both the network of secondary care services, but your point around how it sits in the context of the wider work, the prevention, the place-based agenda, working with partners, and all the stuff that you'll see coming through our strategic approach, and indeed where we're trying to get to with PSB, Public Service Board, and our PB colleagues. So absolutely. And in terms of beds, what's really numbers of beds are important, because that's what wards. But what we're more talking about at the moment is the type of beds, and again picking up some of the learning of the much cherished Chepstow, which we've talked about today. Some of the beds that operate in Chepstow and the model of care that's run by the Care of the Elderly consultant down there is something I said before we want to replicate, because it really does match needs of population. And so for the work we want to take forward, it's about the type of beds and the workforce around the beds and the access to those beds necessarily than the number. So numbers may not change, but the type of beds may change to better reflect the needs. So that was really what maybe I said a bit clumsily earlier. We do need to right size the capacity, but that just doesn't mean numbers. That's sort of the nature as well. But happy to pick up offline with Dr. Chandler as requested, and indeed Dr. Birch, I think it was, Councillor Birch. I'm getting my councillors and my doctors all mixed up.
I know Councillor Birch sounds quite good, actually. Dr. Birch, Councillor Birch, Dr. Birch even. Thank you so much, Hannah, for coming along. We're going to let you go now. We really appreciate you coming along and explaining to us. Really insightful. It's the level of knowledge you've got there is excellent, really, and we look forward to accessing that when we have that meeting about Chepstow as well. So thank you. We wish you all the best, and we hope you have a lovely summer. Paul, if you'd like to come in.
Yeah, Ian's comments with regard to the system, and so this obviously is work on the Neville Hall site, but that work is ongoing in terms of making sure that we're able to give people as much care as close to the home as they can, and that is effective. Just to say that work is going on alongside this work, and will continue to hopefully bring great dividends for us in the future, because that is really the future of an awful lot of healthcare that currently may be delivered in hospitals. So that work is ongoing, and it's an area of great interest for us, and there are a lot of developments there.
No, thank you. Sue, I see you. I'm going to just effectively try to mop this meeting there. So, Sue, have you got any? You've got your hand up for a final question there. Maybe not. Okay. Right. Right, so thank you, Paul. I think that's pretty much. Are there any other questions out there? Peter, you've I say this with respect. You've been quite quiet today. Councillor Strong, Councillor Keir, Rook, have you got any questions?
I am going to have to leave. Sorry.
Thank you. All right, take care, Alan.
I'm so sorry.
No, it's fine.
Happy to come back as any time you'd like, Chair.
Okay, thank you. All the best. Yeah, thank you very much. No other questions. Right. So that's it. Thank you all for coming along this morning. I really appreciate you being very patient with us. Sorry, you could have. You've been really helpful. I do appreciate that. Nothing else from the floor. Some great questions. Fantastic opening question from Chris. So I'm going to wrap this meeting up. We will probably ask them to come back at some later stage. I'm not sure if we can fit it in for it as a joint meeting before October, particularly for the South. So we'll have to wait on that, but it's something we'll have to organise in the future. Ian, thank you for summarising and thank you for arranging this meeting. I know it was a bit last minute and there was a bit of pushback from me, but I'm glad that we've had the meeting now, so thank you for coming along and helping us understand what's going on. That's pretty much it on the agenda. So there's effectively nothing else. So I'm going to wish you all the very best for the summer. I hope you have a relaxing break, and I will see you in the new season, so to speak. Take care. Bye-bye, everybody. Thanks.
Thank you.
Yeah, bye. Thanks.